Welcome back to the Best PT Podcast. This is bonus episode 3, talking about breathing exercises, beginning with diaphragmatic breathing. The purpose of diaphragmatic breathing is to improve ventilation, decrease the work of breathing, mitigate dyspnea, and reduce post-op pulmonary complications. The idea here is that patients will take deep breaths through their nose and out through their mouth. Therapists can use manual cues and instruct the patient to fill my hand with their air, with hands over the diaphragm. This ensures proper diaphragm inflation and not upper chest breathing. Diaphragmatic breathing should begin in supine in order to reduce accessory muscle compensation. Pursed lips breathing improves gas exchange, slows respiration, reduces the work of breathing, increases tidal volume, and increases exercise tolerance. The method here is that patients will breathe in through their nose and have a slow leak exhale through pursed lip. The cue here is breathe out like you're trying to make a birthday cake candle flicker without blowing it out. Segmental breathing is also known as thoracic expansion exercises. The purpose here is to augment localized lung expansion with an emphasis on using manual pressure for proprioceptive input over various lung segments. Pressure is applied by the therapist at the end of expiration and during inspiration, and the patient is cued to fill my hand with your air. You should not impede thoracic range of motion with your pressure. The patient should be allowed to fully expand their thoracic cage during these breathing exercises. Diaphragmatic strengthening involves using cuff weights placed over the diaphragm or the epigastric region. For quadriplegic patients, abdominal corsets are indicated to help facilitate diaphragmatic strengthening. Respiratory muscle training, both inspiratory and expiratory. The main differential diagnosis reminder here is that you need to be able to recognize respiratory fatigue versus respiratory muscle weakness, because strength training already fatigued patients can cause respiratory failure. Inspiratory muscle training, or IMT, is indicated for patients with diminished endurance, beginning at 25 to 35% of maximal negative inspiratory pressure. It's safe to begin at any resistance level that does not cause fatigue, dyspnea, or oxygen desaturation, and is performed twice a day for 15 to 30 minutes per session. Expiratory muscle training simply involves the strengthening of the abdominals and the intercostal muscles. And glossopharyngeal breathing is the swallowing of air into the lungs in order to increase vital capacity, and this is indicated for higher level cervical quadriplegic patients. Active cycle of breathing technique, or ACBT, involves 3 phases. Phase 1 is known as the breathing control phase. Patients perform relaxed breathing at tidal volume with an emphasis on diaphragmatic breathing control. This is performed for 5 to 10 seconds. The patient then moves on to phase 2, or the thoracic expansion phase, with an increase in inspiration to maximal inspiration. Expiration is passive and relaxed. The patient takes 3 to 4 deep breaths, followed by a 3-second inspiratory hold or a big sniff. The PT or caregiver can provide percussion or vibration at this point. The patient then repeats phase 1 and phase 2, and then repeats phase 1 again, and then moves on to phase 3, or the forced expiration technique. It involves a alternating huff with breathing control, with 1 to 2 medium volume huffs, followed again by the breathing control phase, so that relaxed diaphragmatic breathing for 5 to 10 seconds, followed by 1 large high volume huff. The whole cycle is repeated until the patient can demonstrate a non-productive dry huff for 2 cycles in a row. And finally, autogenic drainage also has 3 phases. Phase 1 is known as the unsticking phase. It is a brief period of diaphragmatic breathing, a deep exhale through the mouth, followed by normal tidal breathing, and it is continued until the patient is able to feel secretions moving in their smaller airways, usually performed for 1 to 3 minutes. Phase 2, or the collection phase, involves a slow increase in the depth of inspiration while maintaining normal tidal breathing. So patients will take a deeper and deeper initial breath and then maintain tidal breathing without letting that initial breath out. This phase is repeated several times until the sound and feel of secretions decrease or move more centrally, and this is usually performed for 2 to 3 minutes. And then finally, phase 3, also known as the evacuation phase, involves a continual increase in inspiration depth up to the maximal inspiration depth, followed by normal tidal breathing. Patients should begin to feel secretions move into their trachea and use strong huffs to expel secretions. Again, this phase lasts for 2 to 3 minutes. And then after a 1 to 2 minute break using diaphragmatic breathing, all 3 phases are repeated again until all secretions are expelled. That's it for bonus episode 3, talking about breathing exercises. Bonus episode 4 will talk about postural drainage or bronchial positioning and drainage. As always, the outline will be in the show notes. Thanks for joining me.